So this is an interesting topic, and this is one of the very topics why Zeiss, really benefits from surgeons like us giving courses instead of them, because the application specialists cannot tell you all of the things we're going to tell you, because most of the stuff in this lecture is off-label. Let's start with what is our retreatment rate. Well, for myopia, forget about presbyopia, which is different because the sensitivity for each eye is higher and all of that. But if we look at myopia up to -8, out of 3,592 eyes with at least 1 year follow-up, 14 enhancements were done within the first year. That's an enhancement rate of 0.4% within the first year. Some of these were higher myopes, so they had to be longer. So we're able to say to patients, after 1 year, there's a 0.4% chance that you will have had an enhancement with SMILE. If we go on and look at this after the second year, now we've accumulated the higher myopes that have now matured sufficiently, or the people who were on target at 1 year that might have regressed slightly after 1 year, and we've been very kind and done an enhancement for them. But essentially, 34 enhancements within 2 years. This enhancement rate is lower than LASIK. And one of the things that we're looking to do is to do a matched control study. We have the 50,000 eyes from LASIK, so there's no problem for us to find an exact match. In fact, probably 4 or 5 eyes LASIK per SMILE eye to do a matched control study. By 3 years, there's another 0.5%. By 5 years, now you're talking about progression of myopia or regression, but regression is unlikely. It's usually progression, just a tiny bit more. And so as you can, we did do, this is not matched controls. This is just, this is literally just a cohort of LASIK versus a cohort of SMILE. And up to -8, LASIK, up to -8, SMILE, about the same at 1 year. About the same at 2 years, about the same at 3 years. SMILE -8 to 13, lower enhancement rate than LASIK. And that shouldn't surprise you, right? Because we always knew theoretically that SMILE was likely to be more accurate than LASIK for high myopia, because in high myopia, the excimer laser suffers from the time domain. It's a longer ablation. There is more time for dehydration or what to affect the volume of tissue removed. Whereas with SMILE, it really doesn't matter whether you do a -1 or a -14, which is the maximum we can program. The time of the cutting is the same. The only difference is the interfaces are further apart. So LASIK depends on time, SMILE doesn't. So all of the room conditions, the ablation criteria, all of that adds complexity, whereas in SMILE, it's a geometric lenticle. So this is, this is just a cohort study. They're not matched controls, but as you can see, they're almost the same numbers. So that's kind of interesting, isn't it? Now, like I said, like when I give this talk on a Zeiss podium, I have to, read this out with the lawyers. They give us this to read, that it doesn't represent Carl Zeiss Meditech. Okay, so we talked about already, or started to talk about B scanning and anatomically driven surgery. I'm going to talk about this in a lot more enthusiastic detail next Friday, which is almost my favorite day, because I'm talking about really like the next level of refractive surgery is looking at the cross-sectional anatomy and the three-dimensional profiles of the individual layers of the cornea. And so planning a flap after SMILE needs to be done by knowing the anatomy of where you're going. Where is the centration? Well, you know, you've got the centration of the original treatment, right? So this time, rather than using the Placido system to know where we're centering things, we're going to use, we're actually going to use the actual screen capture of the video of the procedure with the green flashing light in the middle. That was where the contact lens was centered the first time. And so that, if we're trying to do a side cut inside a cap to convert it to a flap, for example, because you know you've got an 8mm cap and you want to do a 7.5mm side cut inside it. Well, you know, that's 250 microns on this side and 250 microns on this side that you need to, you know, make sure you're not getting over the border in the wrong place. So side cut only, you know, the centration is critical, and we have the actual image of the original surgery so that we can confirm centration. Okay, that is what it looked like during the first surgery. So we're going to reproduce that during the second surgery. Now, there are 5 ways of doing enhancements after SMILE. These 2 are off-label. This is on-label in Europe, although I hear that the Circle software will be approved in the States sometime soon. The side cut only is off-label, but you basically use a flap program to do the side cut only and without the lamellar dissection. I'll explain that in a second. But let's go to the enhancement procedure that's official from Zeiss, and it was the first enhancement recommendation, and all the engineers said this is how it's going to have to be, and it's better because you can't cut more flaps in the cornea after you've already made SMILE incisions, which is wrong, but PRK. Now, PRK, as you gathered from me, is a procedure I do not recommend as a primary procedure or a secondary procedure unless you have to. The thing about PRK is that, you know, it has all of the disadvantages I talked about last time in terms of complex pain management, risk of haze. You really should be using mitomycin C prophylactically if you do an enhancement of PRK on top of a cap. Obviously, there's slow visual recovery just from the epithelial wound, but there's a huge, lengthy refractive visual recovery because, as I explained on the previous day, the preoperative epithelium before the enhancement is already a lenticule. So if there's 1.5 diopters in the epithelium and you take it off, if the patient was -1 and you take a -150 lens off, that's -250. That's -250. You now do your enhancement. You need all of that regression to happen in the epithelium before you reach your target. So patients can be +3 at 1 week, and you've got to wait all the way to 6 to 8 weeks before they recover. Not only all the epithelial thickening for the first procedure, but then the little extra from the second. We published the dynamics of the epithelium after LASIK. One of the things I want to show you that's kind of cool about the MS39 is that we have an anamorphic display, which I worked on with Francesco. And here is the bandage contact lens, and you can see the edematous epithelium as it's growing in, yeah? And here you can see it on the final day, all grown up, yeah? This image is, the distortion of this image is that the front surface is fit to a flat plane. So everything beyond it then is relative to that. So you can see how much edema there is in the central cornea here. Even at the time of closure, there's still edema in the central cornea. That's why the back surface looks like it's pointing backwards. And, you know, like I said, I have the slit lamp of the 21st century here next to my slit lamp here of the 19th, of the 20th century, 21st century, 20th century. So side cut only. The principle is that you've got your cap interface and you're going to make a side cut inside, converting the cap into a flap. Jod Mehta in Singapore, they've got money coming out of the yin yang. They can apply for research grants for anything they want on anything, and they get approvals. So they do tons of rabbit work. And they did studies showing that it's easy to lift this if you do it and whatever. The problem with the side cut enhancement is that the diameter is going to be limited by the cap. And the cap is going to be larger than the diameter of the side cut only, because you need a little bit of play because of any possible decentration. So it's unlikely to be suitable for hyperopic enhancements or topography guided enhancements, where you need to obviously have a much larger zone. The last disadvantage is that in the States, you're forced to do a cap of 120. So now you've got this side cut and you're wasting all of this stroma in the flap. And that's a waste. That's a big, 120 flaps they're not used anymore in LASIK, right? No one does 120 flaps anymore. It's like a T-bone steak. It's way too much. So the trick for the US software is to use a flap program, is to program the flap. Let's say you've got your 8, actually in the States, the maximum cap is 7.5. So you're going to program, let's say, a 7 side cut, and you're going to freeze the image from your video of the first surgery, print it, and put it upside down in front of you at the VisuMax, so you know what your centration is. And then you're going to program this flap at 7 millimeters, and you're going to program the depth to be 30 microns deeper than the thickest part of the cap that you've measured on your OCT. What you do is you've got the patient there, and you basically kink the contact glass, the tubing. You kink it, and then you put suction on. The VisuMax is going to think that the suction is now achieved because you're kinking the cable. It's not on the patient. You're holding it. And you look at the numbers on the screen and you count down from 10. And when you get to 6, you let go of the kink. So you're cutting. So during that time, it would be when the lamellar cut is being made, and 10, 9, 8, 7, 6. And you let go at 6. That is when the bed was finished and you're about to do the side cut. Now the machine goes into repair mode. It says, oh, you've had a suction loss. Would you like to continue and just finish with the side cut? And you say, yes, please. Yes, and carry on. It says, do you want to continue using the same contact glass? You say yes. So then you now put the contact glass into the cone, and now you put the speculum in. Would you like me to talk about putting a speculum in? And then you come up and center everything and do your thing. Okay, so that's how you make a side cut with the same software in the States, even though you don't have the Circle software. In the Circle program, you can program these huge hinge flaps, or you can program side cut only, or you can program these junction incisions, which I'm going to show you now. It's called the Circle treatment. So the Circle takes the cap and extends the area that could be used for ablation by LASIK by whatever diameter you want. And then in order to make sure that it's joining the original cap interface, it makes a junctional cut. So it starts by making the junction first, and then it goes out to the periphery and it comes in and joins the junction. Again, Jod Mehta on the rabbits did all of this work, and they showed that it was good for rabbits. So good for rabbits, good for people. And here I am, getting my centration and doing everything with the primary image of the primary smile to make sure that I'm not crossing anything over. And here you are, beautifully demonstrated. You've got here the yeah, so that's the flap, okay? That's the incision of the original smile, and that is the junction, okay? So it's all very nicely seen, and heals by day one. Here's a gorgeous ultrasound scan. Again, this is stretched out, but you can see that you've got your smile interface here, yeah? You've got your post-circle interface. So you've got that step where the junction was onto that interface. And so I've now got an ablation area that's much larger than the original cap area. And what is this? Well, that's a dissection. And this is one thing that you should be ready to find. And don't freak out, it doesn't matter. But it doesn't work great because the caps are not 100% parallel to the surface. And the new junctional zone expansion lamellar cut are not exactly at the height that you expect. And sometimes you end up crossing over from one into the other interface. And when you lift the flap, you lose, the plane. And you'll have on the underside of the cap, you'll see a bit of sliver of stroma that stayed. And so you'll get these things. But the good news is that the central, of course, is the middle of the lenticule. So you're not going to have slivers in that region. You're just going to sometimes see slivers in the periphery here. And we don't use a lot of circle here, by the way, because we use thick caps. There is a circumstance in the very high myopia study where we're using 90 micron caps. And then we would use the 90 micron cap with a circle treatment to create an ablation for an enhancement. Now, I'm getting to the preferred method, the preferred method of enhancement, the number one choice, and that is to make a thin flap. This preserves as much uncut stroma as possible. The thickness chosen is that to avoid crossing into the epithelium and getting a gas breakthrough and avoiding crisscrossing into the interface and creating slivers and a pizza pie that you have to put back together again. So what's our protocol? It's standardized. We have two papers that we published on this. One of them is development of the technique, because not only you have to develop the standard of how to program it, but also it turns out that the lifting technique is very specific. We had a lot of complications actually that we generated. Sadly, we generated a lot of interface interactions when we were developing the flap lifting technique. So I'm going to go through that with you. But the standard technique, so that you can do this, very easily, is obviously you've got a minimum 135 original cap, and you can always do a retreatment as 100 micron LASIK. That's the point. So in the US, you've got a 120, and you can do a 95 LASIK. Now, how does that work? Well, let's say that your cap is at 120, you're in the US, and that the epithelium has thickened by 80 microns. It will not thicken more than 80 microns. I can tell you that because I've studied epithelium for 30 years, right? So the epithelium is not going to be thicker than 80 microns, even with a -10. And so to avoid 80 microns in the epithelium, you want to add 3 standard deviations. So that brings you up to 93. But your cap is at 120, and so that you want to be another 3 standard deviation below that, because you program at 93, but it could be thicker. Your cap itself might have been 3 standard deviations thinner. So as you can see, adding these standard deviations to the programming of the flap keeps you within 3 standard deviations of the cap if it was thinner. So the mathematics of this are very simple, and the mathematics are the same if you do a 135 cap and a 100 micron LASIK flap on top of it. So now we don't actually really, we check the OCT, but we're not as meticulous about 3-dimensional plotting of the cap thickness when we're programming a new flap for the average eye. So here's an example where the smile interface was a 122 in the center at the thinnest. Here's the epithelial map at 62 microns, the thickest. The LASIK flap we planned was at 100. That means that we're 38 microns clear of the epithelium, 22 microns clear of the smile interface. And therefore, we're many microns away from both, and everything's going to be fine. Now, I want to go through the flap lifting technique. And again, this is essential reading. Do not do what I did and what Glenn did. We ended up with a lot of headaches. And believe me, once we settled on this technique, no more dissections, okay? I mean, almost no more. So you come in, and this time, as you get that iris spatula in, what you're going to do now is point it up. Don't point down or you'll go into the interface. Point it up. Once you've pointed it up, you push across, so you're riding along the surface, and come out here and use the both instruments to punch open the incision from the other side so that you get the handshake. Once you've achieved the handshake, leave the iris spatula there and do not dissect the inferior part of the flap. That now becomes a pseudo hinge. You will now use the thicker instrument, which has more separation force, to now come back towards you, towards the actual hinge, and make sure that the instrument is pushed in well inside so that this tip does not punch out of the smile incision and you tear this like we have many times in the past. So you come back towards yourself like this, and then you do the same thing. You swap the instruments around and you use this instrument to hold counterforce with the hinge. And now you use the iris spatula to pull back on this half of the cornea. Once you've separated all this area of the flap, now you go back to the actual hinge with counterforce with the right-hand instrument. And now you separate the pseudo hinge and complete the remaining dissection of the flap. So here it goes. Coming in, watch me pointing up, going across, punch out, miss the incision, and then break the pseudo hinge, and you have a beautiful flap. And it's as simple as a primary procedure. It's like, that's it. I love doing LASIK on top of smile. It's way more pleasurable than doing LASIK after LASIK. I can tell you that. Here's a slow-mo technique. Point up. Avoid the incision, and then use the pseudo hinge and then lift it up. Okay? So once we landed on that technique, I've had one actually, but that's because I got OBL, and that was in a very complex cornea, which I will maybe talk about one day. It was not a regular enhancement. And so here you have an hour post-op. You've got all your interfaces beautifully delineated. Everything looks gorgeous on day one. Another example. Point up, go across. I say point up because when you do a wider, deeper flap of LASIK on top of LASIK, you want to point down and go across, right? So it's the opposite. This is a beautiful example because I left the pseudo hinge very, very intact, and I used this fulcrum technique to finish it off. Yeah. So instead of ripping through, what I do is I use a fulcrum technique by raising the instrument and doing almost like a rhexis of the end of the thing, so it protects the epithelium. Okay. And here's another example. By the way, while you're looking at the bubbles, you need to make sure that you don't see gas breakthrough into the stromal interface of the smile. which you will see. Sometimes when we were very close and we weren't doing this properly, we would see an area here where you get like that on the right, you'd see that bubble inside the interface of the smile. In our textbook, you will have about 15, 20 nasty examples of separation of different interfaces when we were trying to do LASIK on top of smile, and we were trying to develop the technique on how to do this. I mean, when I say nasty, I mean nasty. But you saw from Glenn showing you our 4,000 eye series that despite the fact that we spent a lot of time in the operating room putting Humphrey Dumpty together again, we don't get loss of lines. We're just meticulous. We respect the cornea. We put everything back exactly where it came from, and no one gets hurt. Okay, so now, very important to carry on. This is a very nice example of this thin flap, and look how those microfolds are absolutely beautifully distended by using this slit-lamp technique post with the second phase of flap repositioning. Yeah, isn't that nice? Gorgeous. Love it. By the way, you wouldn't see those folds if you didn't put the fluorescein in. If you just look at the slit lamp with a white light, you won't see that. You will not see them. They're invisible. You'll be upset with yourself the next morning and wonder why the hell that happened, and you'll blame the patient for rubbing their eye. So here's LASIK over smile, and we can see here a magnified view of how you have your interface here and your flap on top. Okay, very nice. Remember that it's different from the LASIK technique that we teach on the bimanual technique for lifting the flap in the first place. Here, you go to the actual hinge and come and dissect downward, right? It's totally different, yeah? We still do this rotation technique, but that's the opposite, okay? So be aware of the small incision. We have actually cut into it a couple of times. In the US, you have a small incision superiorly. And so therefore, a lot of surgeons have said, oh, you have to make a nasal flap. And the answer is no, you don't. Because these flaps are at a much wider diameter. They're 8 millimeters or even 9.1 if you use a program L, use M. You can do a 9.1 millimeter flap. And this is only 7.5 maximum. So you don't have to worry about that. You just do a superior hinge. It's much better. No need for a nasal flap. Nice idea, but think about the geometry. You don't have to worry about it. So what is the retreatments? Well, here's our 4,000 eye database frozen, and we can show you that the enhancements work. One of the things that we learned about enhancements here was that they're very safe, obviously, but we learned that myopes overcorrect. And I could spend 5 minutes explaining this, but I'm not going to do it now because it's really, I want to get onto Alistair's talk in time for the course, but it's to do with, remember I showed you the difference in dynamics between the epithelium after smile and the epithelium after LASIK? Remember I showed you that the epithelium is a hyperopic profile in low myopia smile compared to what it would look like after LASIK. So it's thicker in the periphery because of the minimum thickness. That difference in profile is the reason why you don't add more minus to a myopic enhancement after a myopic smile. So if you did a -10 and they end up -1, you would be plugging in like -125 to correct the -1. And we were doing that. We were thinking that the nomogram was be the same, even though we're the experts of the world in epithelium, and we didn't click. So what was happening was we were putting in too much myopia. It turns out that to correct a consecutive myopia by LASIK on top of smile, you program the myopia directly into the excimer, no adjustments, and you will get exactly on the line. And by the way, it's the same with hyperopia. Okay. Hyperopia, you use 2/3. That's the same because the hyperopic profile is the same. Anyway, the accuracy and everything is fine. The nomogram is now adjusted, so our results that we published were shit because we overcorrected because we used the LASIK nomogram instead of the proper nomogram. But now that we've told you this, you're not going to do that. So astigmatism is corrected well, a little bit of undercorrection in the higher, but this is the technique paper where we showed you how the different flap techniques that we are using to lift it and how we got complications, a lot of them in the beginning. And then we tried something new here and we got 3 complications, but then we went back to the standard technique. And you can see that once the technique was standardized, no more complications. And we now have probably another 100 eyes after this, or 200 eyes even, with no complications. So trust me, that is the method for lifting a flap by doing LASIK on top of SMILE. And if you want to make it better, let me know what we could do better. But stick to that for now, and you'll really avoid all of these complications, accessing each interface, tearing the small incision. We just, so many problems that we generated, a lot of headaches. And I want to remind you that doing LASIK on top of SMILE is safer than doing LASIK after LASIK, because LASIK after LASIK has a greater chance of epithelial ingrowth. And we know that microkeratomes have more ingrowth than if you do a femto side cut inside a microkeratome, and even better if you lift a femto or do a side cut inside a femto flap. But SMILE and then LASIK is actually safer than LASIK and then lift. And so we love doing bilateral SMILE in a 41-year-old for minus whatever, telling them that when they become presbyopic, it'll be a simple LASIK enhancement with presbyon. Okay? 0 out of 100 ingrowths, 4% if you lift the flap. And I thank you very much for your attention on enhancements.